Let me just begin by saying that the Right Care Initiative has been around in California, I think, since about 2007. And it has as its goal, one of its many goals, reducing cardiovascular risk factors in the state of California through community efforts in improving the quality of healthcare. And it's quite a unique collaboration in that it involves healthcare provider groups, insurers, state agencies, and just a variety of different partners, private sector partners and public sector partners as well. And as part of this, we get together on a regular basis in different locations. So there is a Sacramento group, there's a San Diego group, a Los Angeles group, and now a Silicon Valley group. And so today's meeting is part of the Silicon Valley group, which is the newest component of the Right Care Initiative. So I have the pleasure of introducing Dr. Bill Bommer. In the academic world, we talk about the triple threat in the academic departments: the person who is a noted scholar, an excellent teacher, and a community servant. And then in medical schools, there's the quadruple threat, because that we add to the other three pillars, clinical service as well. But Dr. Bommer strikes me as someone who's, I can't think of the word for this many threats. So he's a guy who just does everything. So in his community service realm, he has played remarkably important roles in the American College of Cardiology. He's a member of the California Executive Committee. He served as president, vice president, governor, and member of the board of governors. He is a professor at UC Davis, and he directs the UC Davis Cardiology Non-Invasive Services Program. He's had a remarkably productive career as a teacher. He's trained over 200 practicing cardiologists, and he's been a very active researcher as well. He's been principal investigator on many NIH and NHLBI trials, in addition to international research. He's a member of 50 international, national, state, and university education commissions. And he has developed software and private sector things. He has been a prolific author, publishing more than 250 scientific publications. He's received over 100 honors and awards, and he's presented more than 1,000 papers at meetings. So it's just a remarkable pleasure to have Dr. Bommer with us. By the way, beyond all this, he's a really good guy, and that he is an accomplished athlete. He's a marathon runner, and he's a skier, and just a pleasure to get to know. So, Bill, thanks so much for joining us today, and we look forward to what you have to say.
Okay, just wanted to take the time before we have Dr. Bommer share his slides, remind everyone that all of our participants are currently muted, and if you do have any questions, comments, or concerns, to please use the raise your hand button on Zoom, or to submit your question into the chat box. And with that being said, we'll be allowing Dr. Bommer to share his screen now.
Okay, welcome everyone for the second time. Thank you for the introduction. As I said earlier, we were initially going to have this slide as our initial one, Cardio-Diabetology, patient-centered approach that we wanted to discuss. Next slide. In the middle came the COVID virus shown here, which altered the relationship that we have with our patients in the treatment of diabetes and its cardiac manifestations, clearly interferes with our treatment plan for these individuals. As you can see, we're also having treatment areas of interaction even today on this presentation. Next slide. So again, the standards are listed here, and the references to the American and European Diabetes Association and their guidelines, and the references listed here for the review article or the meta-analysis that will be published later today on cardiovascular considerations in COVID patients, including patients with existing cardiac disease and individuals with diabetes. My disclosures are shown here. Next slide. So this is the problem as we see it on the left, the new COVID virus shown there. And if we look to the right bottom of the screen, you can see that on February 19th, 2020, a short time ago, we received a patient who had respiratory distress, became ill, required to be intubated. We requested on the 19th a test for COVID-19 for that individual, but it was turned down at that time for the next 5 days. And the reason was that the patient had not traveled outside of the US or had contact with individuals who had COVID-19. Well, when we finally were allowed to get the test on this patient on a ventilator, the test came back positive. And as you can see in the middle on the right, the CDC did confirm that this was the first community-acquired case of COVID-19 in the US at that time. So on that date, February 19th, was number one community-acquired case. And the slide on the top shows that the prevalence of this has increased dramatically from 1 to 173. So we went from 1 to 173 in just over a month. And I should point out that it was not just 1 to 173, it was 1,000 times more than that, because we went from the first case to 173,000 cases in the US. A very rapid transmission of this virus. Next slide. What leads to that? Well, you can see in the center is the SARS-CoV-2 virus, which is responsible for COVID-19. You can see that it's intermediate in lethality. On the right is influenza at the bottom, and it is approximately 20 times more lethal than influenza, yet it is 20 times less lethal than the ones on the top, Ebola and smallpox, which are shown there. So in the viral group, it has intermediate lethality that we see there. Next slide. This shows the infection rate for these viruses, and you can see that COVID-19 lies again about in the middle for infection rate. It is in fact more infectious than Ebola or influenza, with about 2.5 individuals infected for every case that we identify. And it is less infectious than smallpox or measles, which infect far more people from the index case as shown on the bottom. So intermediate infection rate, intermediate lethality for this agent, but this agent, next slide, continues to spread at a rapid rate throughout the Western world. And you can see initially in China, where it started out, and then in Asia, and then followed by Europe and the United States. The prevalence of this disease continues with a doubling rate of every 3 days, approximately. The number of cases doubles. So a significant escalation of this. And as we said earlier, in the US alone, we have 173,000 cases at this time, and the curve is still going up at this time. Next slide. So what is the relationship with our original topic, which was cardio-diabetology in COVID-19? Well, the relationship now is that if you have a normal individual, pretty healthy, the mortality from this disease is a little less than 1%, but in the presence of cardiovascular disease, it goes up to 10%, diabetes up to 7%. So these both increase significantly the lethality of the disease, as you can see in the group, initially in the top from China, and then in Italy, shown on the bottom. You know that about 35% of the individuals who die of COVID-19 have had diabetes as an initial comorbidity for that. So it plays a big part with both diabetes and cardiovascular disease. Next slide. So what is the mechanism for this? So the COVID virus is seen on the left with spikes. These spike proteins link directly to a protein that is expressed on many cells in the body, especially in the respiratory cells. And that is the ACE2 protein or receptor. And the diagram in the middle shows that there is a direct attachment between the ACE2 protein, shown in green, and the COVID-19 virus, shown below it in purple. There's a direct linkage that we can figure out the exact amino acids and the sequence that allows to that. This linkage allows the COVID virus to enter directly into the cells with the ACE2. And that allows them to migrate into the respiratory cells where they, in fact, take over the RNA replication in the cell, turning out millions of copies of the COVID virus at that time, which obviously injure and eventually kill the cell and lead to the release of then millions and millions of new copies of this COVID virus. So the reason that we mention it is that this ACE2 receptor, which all of us, all humans have in many of our organs and especially in the respiratory system, leads to the entrance of the COVID virus. There are certain things and entities that increase the expression of the ACE2 and could potentially offer more doors for this virus. Individuals with diabetes have an upregulation and expression of the ACE2 protein, and individuals who are on ACE inhibitors or angiotensin receptor blockers do appear to have a higher expression of ACE2 on the cells, and this could potentially open more windows for this virus. Next slide. So individuals who have diabetes are at higher risk. Other risk factors include existing cardiovascular disease, those individuals who have a reduced immune activation, those individuals in cardiogenic shock, metabolic disarray, coagulopathies, or immobility. Those individuals are at higher risk for acquiring this disease. And if they develop a cardiovascular complication shown on the right, those complications so far, and we're adding these up as they occur, include arrhythmias, myocarditis, acute coronary syndrome, just like having an acute myocardial infarction, venous thrombosis, and now we've seen in our hospital now arterial thromboembolic disease as well, cardiogenic shock, and heart failure. All can be cardiovascular complications of this disease occurring in diabetics as well as others. Next slide. So this shows the meta-analysis that we referred to earlier and shows the frequency of cardiovascular risk factors in mostly the Chinese population, because we don't yet have a lot of data out of Italy or out of the US at this time. You can see highlighted here in the center, diabetes has a higher prevalence of presence in this disease, being present in 7 to 17% of the individuals who have COVID-19. But if we look at diabetes in the middle, cardiovascular disease, hypertension, and other cardiac diseases, you can see between cardiovascular disease and hypertension and diabetes, we have a fair significant prevalence of risk factors associated with COVID-19. Next slide. And those individuals who in fact have diabetes and COVID-19 are at higher risk, shown on the top, of winding up in the intensive care unit and of having severe versus non-severe disease and having a fatal outcome from this for that. So the presence of cardiovascular disease as well as diabetes increase both the prevalence as well as the severity and the poor outcomes from this disease, as shown in the meta-analysis from China. Next slide. What do we have to fight this? Well, at this time, you're all aware of social distancing, trying to keep away, cleaning, washing hands, protecting respiratory droplet infection at this time. We are looking at, and trials have been initiated, approximately 50 or more trials, soon to be 100 clinical trials trying to consider antiviral treatment and other treatment for the acutely infected COVID-19 patient. It will be a year or more before we have prevention vaccinations that are available. So right now, clinical trials are focusing on ways of reducing the replication rate or the infection rate of the COVID-19. And you can see that the typical antiviral therapies that have been turned to, ritonavir, ribavirin, and remdesivir, have all been brought out because they may, in fact, inhibit or reduce the proliferation of the virus in the cells and the replication of this RNA virus. Next slide. Other trials that are ongoing are shown here that are monoclonal antibodies. Chloroquine and hydrochloroquine have been in the news, as you know, that may alter the infection rate for entering the cells of this virus. And other immune activating and immune inhibiting agents may be shown as well in these trials. Notice that all of these trials that I've alluded to with the antiviral agents have significant drug interactions with agents that we routinely use in cardiology and have potentially cardiovascular adverse effects. So these drugs that we may use are not without possible side effects that could be adverse in a patient with existing cardiovascular disease or on those agents. Next slide. This shows the additional agents to reduce inflammation. You realize that part of the virus injury is because of the damage caused by the actual virons, as it in fact destroys cells. And some of the damage can be seen from an aggressive immune response. The question is, which of those do we use? And those agents that can inhibit IL-6 or reduce inflammation are shown on this slide and are being actively considered in clinical trials today. They also have side effects, as we all know from prior experience. Next slide. And summarizing those, we can see that if you're looking at using antiviral agents for individuals with cardiovascular disease and COVID-19, you have to be concerned about interactions with anticoagulants, antiplatelet agents, statins, and antiarrhythmics, all of which we frequently put our cardiovascular patients on for that. And these drug interactions can be significant. Next slide. This shows also interactions with beta blockers, antiarrhythmics, and anticoagulants as well for these. So we have to be cautious when we put the individual with cardiovascular disease on them of the drug interactions and requirements for adjustment of dose. So it's not just simple that we add an antiviral agent. We have to consider all the potential interactions, including drug interactions with this. Next slide. Now, based on the information that we have, so far preliminary, mostly out of China, the societies, cardiovascular societies, have come up with at least preliminary recommendations or guidances that are shown here. So these are recommendations of the American, European, and Canadian societies for how to treat these patients before we really come up with a complete amount of information on them. So you can see that ACC recommends developing protocols for dealing with a patient who comes in with a heart attack, acute coronary syndrome, cardiogenic shock, myocardial, insufficiency, and they need to have protocols for that to handle, because treating these patients is different, and actually accessing these patients is totally different as well. One case that comes up is whether, as I mentioned earlier, there's an increased expression of ACE, of the ACE2 in individuals who are on ACE inhibitors, AR blockers. Should we continue that therapy, which is a potential window for this virus or not? And there is some unclear discussions about this because we really don't have enough data yet. But I think clearly we would all recognize if a patient came in and progressed to shock, that probably we may want to discontinue an antihypertensive, an ACE inhibitor or AR blocker, just because we'll need pressors to support their blood pressure, and this would complicate the pattern. Whether or not stopping ACE or ARB would reduce the infection rate is something that has not yet been tested, and we don't have data on that yet at this time. Next slide. For our providers, our guidelines are we need to stay away from patients. So e-visits and telehealth are now being promoted to avoid having a patient come in who's an outpatient for that. And obviously, if healthcare workers get symptoms, we want to avoid exposing them to patients who could be, in fact, have a very serious compromise because of the infection from this. We're limiting elective procedures that do not need to be done. We expect that this limitation will be a month or two, maybe 3, that we'll want to reduce that so that we don't provoke in situations where a patient could be exposed to this. For healthcare systems, shown on the right, we can see that healthcare systems are really scurrying now to provide sufficient protective gear and equipment for our individuals who are providers to make it safe. That includes masks, gowns, masks, gloves, etc. For those individuals. And we need to educate our patients and our family of how to particularly avoid this significant risk to them as well. And obviously, healthcare systems need to be cooperative and continue quarantine on hospital personnel who may have been exposed to this. Next slide. So in summary, we can see here that minimizing the COVID-19 exposure means that we're going to do fewer procedures for cardiology, which would increase the risk. We're reducing or eliminating elective procedures. For the critical care patient, where we have to go in and see them, we're using personal protective equipment to try to keep us separated. We have to raise the risk of airborne contamination in this individuals. We have actually seen individuals with intubation who were able to infect staff in the hospital. So we need to be particularly careful about anything that would aerosolize the, in fact, COVID viron at this point in time. Things like echocardiography, routinely ordered, may not need to be, should be delayed at this time. And we may need to do a more limited exam in those that we have to, in fact, evaluate their left ventricular function. Our overall goal is really to reduce or eliminate outpatient visits as much as possible using telemedicine for that. And for the inpatient cardiology patient, we do not need 6 people in the room on rounds for that patient. We may want to limit it. We're actually putting iPads in the room so that maybe clinicians don't have to necessarily enter the room to get a morning round evaluation of the individual. And teaching rounds have taken a big hit because we no longer can walk around with students into the room and show them physical diagnosis. Now, the irony is shown on the right, where I would tell you that a month or 2 months ago, we had a grand rounds at our hospital, emphasizing the importance of physical diagnosis and making the exam, and actually going into the rooms on hospital rounds so that the staff and everyone could appreciate the patient, and the patient actually benefits from this by seeing and interacting with the personnel on a close basis. The teaching is much better in that case. Now, the two bars there show that that's totally been eliminated in just 6 short weeks at this time. And we've swung to the top where we now have to enter the room in most cases with protective equipment on when we enter. And we're doing more and more teaching through teleconferencing as we are today for that. So we've totally eliminated that personal contact that we had. We're experiencing entirely remotely through video at this time to reduce the, in fact, infection rate for this agent. Next slide. And here are, again, general recommendations. If you're COVID-19, you need to stay 19 negative. That means you have to practice hand washing, clean and disinfect anything, wipe down surfaces, and social distancing for that. If you are, in fact, a patient, we'll keep you out of the clinic at this time. If you have prior cardiovascular disease, you still need to be treated sometimes for heart failure, monitor your weight and other things. We're trying to do all of that through telemedicine remotely, those individuals. And when they do have to come in, we have to, in fact, use personal protective equipment in many of those situations and avoid having your patients going to high-risk areas with crowds. For those individuals or patients who are COVID-19 positive, then obviously that's a different situation. You already have the virus, and we have to focus now on the cardiovascular sequelae of this disease, monitor for myocarditis, heart failure, cardiogenic shock, acute coronary syndrome, thrombosis, both of the arterial and the venous system, and cardiomyopathy in that situation. We do know that individuals who come in and that we've seen, they come into the hospital, they're okay, they're not immediately showing these features, and then 5 or 10 days later, they develop the overt heart failure and cardiogenic shock at that time. So it's not all present on their initial presentation, but it develops 5 or 6 or 7 days down in the prognosis of the disease. Heightened awareness has to be there. You can go to bed at night saying that patient is stable with COVID-19, and at 4 in the morning they wake up with severe symptoms and have to be intubated at that time. So you cannot go to sleep on these individuals and say they'll be fine tomorrow. You have to closely monitor them. And so your hospital has to be set up for careful and closer monitoring than we would normally do in many of our patients. Next slide. So we're going to discuss cardio-diabetology, and we're going to cover the first 10 issues there, and we're going to skip the last 5 because of time. But in each of these areas, COVID-19 plays a part. We're going to discuss populations, classification, prevention, comorbidities, behaviors, targets for glycemia, technology, pharmacology, cardiovascular risk, and some of the microvascular complications. Next slide. So we all know diabetes has 4 types. Type 1, seen from autoimmune disease. Type 2 is progressive, gestational in the individual who, in fact, is having pregnancy, and monogenic diabetes shown there. Of these 4 types, next slide, type 2 is the most prevalent in our populations, especially in our cardiovascular patients. The type 2 is seen in the darker blue, and you see that it constitutes literally 3/4 of all diabetes presentations in this time. So type 2 is the big prevalent type of diabetes that we're seeing. Next slide. And that prevalence continues to increase dramatically, going from 300 million, and we expect by the end of this century will be upward or over 1 billion patients in the world today with type 2 diabetes. We say that's an increasing prevalence of a scary disease. Why is it scary? because cardiovascular death doubles and mortality seems to double in individuals with diabetes. And in our hospital, we know that 70% of our diabetics actually die, not of diabetes, but of cardiovascular disease secondary to the diabetes. So it is a very significant cardiovascular killer. 2/3 to 3/4 of your patients in your diabetes clinic or office are going to die of cardiovascular heart disease. That is a significant problem. We need to screen for those individuals with diabetes and detect them early. Next slide. And we can see that diabetes is also going to shorten your life for your patients, anywhere from 6 to 7 years, shorten lifespan if you develop diabetes as an adult. Next slide. So what is diabetes? Well, pre-diabetes is a fasting glucose of 100 milligrams or an A1C over 5.7 for pre-diabetes. Next slide. Actual diabetes is a higher glucose, 126, and a higher A1C, usually over 6.5 at that time. We monitor these patients mostly through fasting glucose and A1C. The glucose tolerance test can be done. We do it less often today. Next slide. Now, who should be screened for prediabetes if you're asymptomatic? Well, obesity is a big thing. And if your body mass index is over 25 kilograms per meter square, you have one additional risk factor, a family member with it, high blood pressure, physical inactivity, or other diagnoses, then you should be screened for prediabetes. Even if you don't have diabetes, you're asymptomatic, you're still at risk for prediabetes. We want to detect it early. Next slide. And this can be done on this easy card produced by the Diabetes Association, American Diabetes. You can see that the high risk for this is increased weight and age. Both of those carry a maximum risk point of 3 for that, and family history carries 1 and physically activity. So as you gain weight and age, your risk for prediabetes goes up significantly. You can use this risk card to make a quick and fast determination in your office. Next slide. So what do we do if we identify prediabetes or diabetes? Lifestyle interventions, number 1. If you can lose weight and increase your exercise, there's a good chance you can prevent going from prediabetes to diabetes. In addition, if you start pre-diabetics on metformin, you can reduce the chance that they will become diabetic. But if you look at the 2 of these, actually lifestyle interventions was superior to metformin in preventing the conversion from pre-diabetes to diabetes. So it is the preferred one. You want to administer that in all of your individuals, and only if that fails, then we would also add metformin at that time. Next slide. This shows that the approach to glucose targets has to be, in fact, personal for the patient. If we look on the right side of the slide, we see that there is an A1C. Average, we try to get the A1C at 7 or less. We may want more stringent control in individuals who are starting early. They're younger, they're motivated, they have resources available. We may want to aim for a lower target, 6.5 in those individuals for that. On the other hand, to the right of the slide, if individuals are older, have fewer resources, are less motivated, we may want to accept a less stringent goal, that is 7.5 or in the 7s for those individuals, so that we do not precipitate hypoglycemia or other significant problems in the individual. Next slide. So again, glycemic control starts with lifestyle. First of all, we want weight optimization, losing weight, healthy diet, and we want increased activity for exercise, and we want to ban smoking in those individuals. Next slide. Therapeutic options are a lot. We've had lots of agents and trials looking at glycemic therapy in our individuals. There's probably over 100 trials that are out there. The drugs that we use that are popular are shown on the left. The less popular ones are shown on the right, but all of these have had an effect in lowering glucose. If we look at the ones on the left, metformin, sulfonylureas, TZDs, DPP-4s, SGLT2s, and GLP-1s are our most popular oral or other non-insulin agents at this time. Next slide. In insulin, we have a variety of options that are available, short-acting and long-acting insulin. Next slide. And what you can see is in many patients, we may have to combine a short-acting regular insulin or rapid one during meals with a longer-acting one that will go 24 hours or longer in those individuals. So those make for convenience in many individuals and allow us to get better or precision control of their glucose. Next slide. Now, all of us who have been sub-interns or interns or started out in the healthcare provider area got our start by getting assigned a patient with diabetes in the hospital to try to control their glucose in a hospital situation. Titration was important in those individuals. Careful titration is important to avoid overreacting and getting too low a sugar or too high a sugar at that time. And there are protocols available for gradually titrating that in many patients. And it does require some time and effort if you're managing insulin in a diabetic patient. Next slide. But the important thing is once we get control of glucose and we're avoiding hyperglycemia and hypoglycemia, we have to be concerned again about the cardiovascular outcomes in these individuals. This slide from Finland shows that if you have on the left cardiovascular, have diabetes in yellow, you're going to double or more your chance of having a heart attack or dying of having a stroke or death. And on the right side, what it shows us is if you've had a prior heart attack, stroke, and in those individuals you also have diabetes, your risk goes up even greater. If we look at the top of the yellow bars, we see that individuals who've had a prior MI and have diabetes have a 40 to 45% chance of dying in the next 7 years from cardiovascular disease. That's a prognosis or a mortality as severe as individuals who have aggressive cancers. So realize that diabetes with cardiovascular disease is highly lethal in individuals and leads to almost a 50% mortality at 7 years in these individuals. Next slide. So how do we prevent that? Well, we can get better at what we're doing. Intensive care in a clinic was designed in the STENO2 trial. They used intensive therapy in a diabetes center treatment group to say, let's do, compared to standard care, a more intensive clinic therapy. Next slide. And what did they show in that slide? That the differences in aggressive treatment, which included insulin ACE inhibitors, angiotensin receptor blockers, statins, aspirin, typical intensive therapy we'd throw at a cardiac diabetic, were important because on the right, they reduced complications like cardiovascular disease, nephropathy, retinopathy, and neuropathy by approximately 50% or more. So intensive treatment in a dedicated diabetic clinic can have significant impact in improving their prognosis and reducing complications. Next slide. Shown here, it also reduced cardiovascular endpoints, almost 50% in this situation, and the need for coronary interventions like PCI or CABG, again, by 50% or more. Next slide. Now, on the left, it shows that this Steno-2 trial, intensive clinic therapy for diabetic treatment, did significantly reduce events like stroke, MI, interventions, vascular surgeries, and amputations, all of which were important. On the right, in the underline, it shows that these significant relative risk reductions were also associated with 20% absolute risk reductions, and predicted number needed to treat was 4 to prevent a cardiovascular event in these individuals with high risk. That means if we treat just 4 high-risk patients in this clinic, we will in fact prevent a significant cardiovascular poor outcome in these individuals. Number needed to treat is 4, is very favorable. Tells you you treat 4 patients, you're saving 1 event in these individuals. Next slide. So knowing that intensive therapy, number needed to treat is 4, is so impressive in reducing events in these individuals, how are our healthcare systems doing? Well, you can see on the right in the outline box that getting patients with diabetes at reasonable control for A1C, blood pressure, cholesterol, and non-smoking status is achieved in a whopping 14% in a series of individuals, meaning 6 out of 7 patients with diabetes who could be significantly helped by this therapy are not meeting their target goals for a variety of reasons. So we are, as a healthcare delivery system, doing a very poor job of controlling these risk factors, which we know would significantly reduce events in these patients. Next slide. So what are we doing? Well, at UC Davis, we're trying to do better. We have a cardio-diabetes clinic team shown on the upper right. This is a multi-specialty team, pharmacists, clinicians, educators, diabetic people, smoking cessation educators, physicians, nurses, all joining together in a combined effort to try to reduce these cardiovascular events. We look at the slide on the left and we see when individuals come in, we assess their key patient characteristics. We want to know about their lifestyle, their characteristics, their family, their in-home issues with motivation, depression, their cultural and socioeconomic context. We then move on to factors that would be influenced in those individuals and their individualized, personalized goals that we try to develop for weight, for glucose, and for their ability to exercise for that. Moving on, we develop a shared decision plan, meaning we don't just write out the prescription or the plan for the patient. This is a joint decision between the patient and the clinician or the healthcare provider to develop this plan. We need them to buy into this plan. Why? Because the next step is they're going to agree on the management plan and they have to sign a contract. This contract outlines what they're going to do, what we're going to do, and what our targets are aiming at that point. And I think this contract and official signing of it and having that in writing is very important for the patients in allowing them to completely sign on to this treatment plan. We then implement the treatment plan, which involves a 2-month period where they come in 3 times a week. They have education programs. They have cooking classes there. They have to cook food and show us how they're doing, how they're eating in front of peers. They exercise, and we have educational plans that go with them. It takes a village to actually create an intense plan like this. Now, we then monitor them as they go through the program to see how they're doing, what targets they make. Success is amazing. Patients often lose weight when they couldn't lose it before. Their in fact, enthusiasm increases. They become the best advocates that we have for an intensive program. We then review their progress as we go up to the top and agree on new management plans as we change our targets with time for that. Now, that was the plan of the intensive cardio-diabetes clinic team that was, in fact, sponsored and encouraged by both the CDC and CDPH with them. And this is a plan that seems to work. In the middle of that, on the bottom right, you see COVID-19 showed up. COVID-19 ended this program that I just described in a personal contact and site review. We had to separate the personnel on top, could not get within 6 feet at that point, and we had to separate from patients at that time. Now, what do we do now? Everything is administered the same way as it was before, but remotely. So all of the exercise classes and recommendations are made through telemedicine. We have a direct contact. We do use, as we're using now, both Skype and we do use the online programs that we're using here, Zoom, to actually interact and have sessions with all our patients. We do cooking on the internet, on Zoom. We do exercise, we do our education, we do our counseling on it, and we do our pharmacy adjustment of medications with that. So everything that we did before in person on site is still done face-to-face, but at a separation required by the COVID-19. So we're adjusting to it. We found that we can do many, if not all of the things through our remote connection. Next slide. So what are our recommendations? We do recommend exercise in our individuals in the intensive program, 150 minutes a week of moderate or intensive exercise are required. And whereas it was in a central room with everyone exercising together, now they have to do it through Zoom, and they are sharing those videos. Next slide. Smoking cessation is important, not just telling your patients to stop smoking. It's not recommended. We require that they actually, if they're smoking, get counseling, and they have to sit down with a counselor and talk about it to figure out what is driving their smoking. And we initiate therapy in those individuals. It's not enough just to say stop smoking. You have to hit hard with counseling and treatment modalities to try to, in fact, achieve that. Next slide. We also use statins for individuals who have both diabetes and prediabetes as well. And we continue that in almost all of our diabetics who are tolerant of statins. We do assign the individuals with diabetes an ambulatory glucose monitor that is available. We're looking not just for A1C, average glucose. We want to know how often are they in the range that we want for their glucose, not too high, hyperglycemia, not too low, hypoglycemia. Next slide. And a printout of that is shown here. It's important not to just have an average glucose with a reasonable A1C, but to avoid the high peaks and the low peaks. The low peaks are increased risk for a cardiovascular patient. For hypoglycemia, we want to avoid both of those. And the glucose monitors allow us to see how often we're in the target range and how often we're missing it. And sometimes we clearly want to avoid hypoglycemia in the evening or nighttime hours, which presents an increased risk. Next slide. And here again is our personalized approach. Not every patient who comes in gets the same assignment or prescription. Again, individuals who are younger and more motivated with resources, we're going to aim for a lower target. Those individuals, they do well on the glucose monitoring. They seem to adapt to it. It's like having an additional watch or smartwatch available for them, and they're willing to participate with that. Older patients with comorbid disease who don't have resources and don't have the ability to interact with these, we may accept higher targets for their A1C. Next slide. The glycemic recommendations that we have are trying to keep people on average 7 or less for that. But as I said, it's a personalized approach. Next slide. Hypoglycemia is one thing that we do want to avoid because of the significant neurologic complications and cardiac complications it can cause. Individuals who have evidence of hypoglycemia are provided with glucose so that, that they can, in fact, treat that initially in our original clinic and now at home, so they have access to that. Next slide. And we want to educate them on what some aspects of their disease that may precipitate hypoglycemia in those individuals. Certainly individuals who are on insulin are at risk for this. Sulfonylureas are also at risk for hypoglycemia. Those individuals who have brittle diabetes, longer duration, or kidney disease, frail, or cognitive impairment are at higher risk for it. We want to avoid that in those individuals, especially patients who are on multiple drugs as well. Next slide. We want to, for patients who are prone to hypoglycemia, make sure they have access to glucagon as well. Glucagon can be a rescue in an individual who is not able to ingest glucose at that point in time. And family and other personnel with the patient should be aware of how to administer that when needed. Next slide. When we use glucose monitoring, we do realize that individuals, literally, the monitors are not perfect. They may interact with other things, other chemicals or drugs that they take may alter the, in fact, accuracy of the glucose monitor. So we want to be careful in those situations. If we get readings that don't make sense, we want to look for other reasons that the monitor may be erroneously measuring. Next slide. But that being said, we can say that in general, these glucose monitors are pretty accurate. 95% of them are able to get a glucose within 15 milligrams per deciliter, and some are 12 milligrams per deciliter. So we do believe that they are pretty accurate, and the patient can rely on them. Next slide. The monitors that we use are shown here. The most intense monitor continually measures it, and if the glucose is headed low, it will send an alert, and if the glucose goes below a certain level, it will sound an alarm, which can trigger not only the patient's cell phone, but a caregiver's cell phone as well. So those are pretty much for type 1 diabetics or those who are prone to significant hypoglycemia. The intermittently scanned one, scanned well with just a cell phone, when you swipe it by, can be useful in individuals, and if they have not experienced problems with severe hypoglycemia, this can be good enough to allow them to help regulate their glucose in that situation. These are available to our patients in the intensive clinic as well as now in the home remote adjustment to that, and they have helped the individuals gain confidence in their glucose and given us some comfort to know that we are trying to maximize their time in the window where we want to keep them for glucose. Next slide. Now, obviously, in a type 1 patient, you have the ability to combine an insulin pump with a sensor system, and we do have an occasional patient who is on that. This is typically for the type 1 patient, but it provides essentially an artificial pancreas for that individual. Next slide. So let's get back to the cardiovascular risk now that we've managed glucose in these individuals. Next slide. And this shows that in individuals, we need to assess their cardiovascular risk. Starting in about 2008, when we had a paper that came out on rosiglitazone showing that there was a possibility rosiglitazone is a potent antiglycemic could actually raise cardiovascular event rates or increase event rates. There was a decision by the FDA to closely monitor the glycemic drugs to make sure they did not increase the cardiac complication rate more than about 30%. So all drugs introduced for glycemia since 2008 have had to have large-scale trials in cardiovascular high-risk patients to make sure the risk is not there. But the advantage of that is they've also given us additional data of these drugs in patients with existing cardiovascular disease. So individuals who come in with diabetes, we want to assess right away, do they have existing cardiovascular disease, heart failure in that setting, because we may adjust our therapy for glycemia based on that pattern, as you'll see. Next slide. So what are our treatment goals for a diabetic in our clinic? Well, blood pressure is not to be forgotten. It's still important in a diabetic patient, and we aim for a blood pressure target of under 130/80 when they can safely tolerate it at this time. In individuals who have existing cardiovascular risk above 15%. So if you have existing cardiovascular disease or a higher risk, 15% of acquiring it in the next 10 years, and you're diabetic, we want your blood pressure to be under 130/80 if you tolerate it at that time. Next slide. So what are the trials in lowering blood pressure? They're all pretty good in diabetes. And you can see in the top circled in the red box individuals, they looked at targets which were more intensive, that is going to under 120 in the ENCORD trial, and in the advanced BP and the HOT trial, they looked at lower targets. And in general, in those individuals, there was a reduction clearly in strokes and some deaths and cardiovascular events in those individuals. So we do want to use lower targets in those individuals. The bottom trial was SPRINT, and diabetics were actually excluded in that trial. But in that trial, it looked at older individuals and showed an additional reduction. If we aim for a target of under 120, the actual achieved blood pressure in that group was a little bit less in those individuals. It was about 121 versus 136. And in those individuals who were older, there was a benefit if they tolerated the lower blood pressure. Next slide. So we can come out with a pattern of or a flow chart for individuals with diabetes. If they in fact have a high blood pressure, we want to put them on at least 1 or 2 agents. And especially as you'll see this flow chart, if we get down to the column or this row that says albuminuria, albuminuria means they have renal disease. And in any diabetic who's got evidence of high albumin in their urine, we want to initiate an ACE or ARB, an ACE inhibitor or an ARB, angiotensin receptor blocker, in the individuals as preferred treatment for them. They may need other therapies as well, but we want to include ACE or ARB because we do know in diabetics, ACE or ARBs are renally protective in those patients who have albumin in their urine. So not only is it seem to be protective for the diabetic patient, it's especially helpful if they have early renal disease in that situation. So ACE and ARBs are strongly recommended in diabetics, especially those with evidence of any type of renal disease. Now, once COVID-19 came into view, as I said before, ACE or ARB therapy will increase the expression of ACE2 on the cell surface, which is a window for entrance for COVID-2. At this point, we're still recommending, and the societies are still recommending, to continue ACE or ARB in your diabetic patient. But again, I said, if you had a patient who was on an ACE or ARB and diabetic and came in and they in fact had COVID-19 and they dropped their blood pressure, I would probably back off of the ACE or ARB until we can stabilize that patient at that time. Whether we wind up recommending any restrictions on the use of ACE or ARB in diabetics in the future is yet to be determined once we get the data. Next slide. So COVID-19, as I said before, occurs in diabetic patients. Higher incidence of individuals with this disease have diabetes in this population. And the ACE and the ARB could in fact increase the risk for it. But right now we don't have data to say yes or no. And the societies are intermediate in their recommendations at this time. Next slide. So our recommendations again, blood pressure is very important in diabetics. It's responsible for a lot of their disease and strokes. So we want to step on that right away to eliminate hypertension in our diabetic population. And for those not meeting target, we do want to consider ACE or ARB in those individuals. And again, if they have any renal disease, we want to preferentially go to the ACE or ARB in that situation. We may want to add mineralocorticoids later in those individuals, not at target. We can use other agents in those individuals as well. So there's no reason why you couldn't add a diuretic or a calcium blocker in those individuals with diabetes. Next slide. Now, when we talk about glucose management or control in the diabetic, we have a number of trials that have been done. As I said, there's probably well over 100 trials for anti-glycemics in diabetics. We look on the left of the slide, we see that the trials, UKPDS, Accord, Advance, that in fact lower glucose also reduced significantly microvascular complications both during the trial and in follow-up. So all trials in lowering glycemia have shown an improvement by a reduction in microvascular complications. But if we look towards the middle and right, we see that these aggressive, intensive trials did not significantly reduce during the trial cardiovascular complications or mortality in those situations during the trial. And one trial in red, the Accord, actually slightly increased mortality. So these trials are very good in the previous agents in reducing microvascular disease, not doing a good job in reducing cardiovascular and overall mortality. Next slide. If we look at the UKPDS trial shown here, we can see intensive therapy by itself during the trial did not lower mortality. There was some legacy that we saw out 10 years later where there was some benefits that were seen from that. But intensive therapy with sulfonylureas by itself was not dramatic in reducing cardiovascular or mortality. Next slide. But we do see in a sub-analysis retrospective of the UK-PDS trial a benefit from metformin used in the control compared to conventional or standard glucose control, seen both during the trial in red and in the legacy of the 10 years after the trial in blue there. So metformin came out in this trial to be reasonably protective from cardiovascular and all-cause mortality. Next slide. This shows that in both the end of the trial and 10 years later, that there was a reduction with metformin of microvascular disease, myocardial infarction, and all-cause mortality that was significant in this analysis that was done retrospectively. So we do recommend metformin as a reasonable drug for our diabetic patients. Next slide. Other drugs that have come out, the DPP-4 inhibitors shown here, the DPP-4's meta-analysis or of the first 4 trials shown here, shows in red that these trials, after the FDA required them to be studied, did not increase cardiovascular events. In fact, they were either neutral or showed a very small reduction in MACE events. Pretty much we could say they were neutral, no significant change in the primary outcomes. You can see of 1, 0.96, 0.98, and 1.02. But they appeared to be safe to use in diabetics, did not increase mortality more than 30% in that situation. Next slide. So DPP-4s appear to be safe or neutral in that case. The next group that we're going to look at is the GLP-1s. This group that came out were the first trials are shown here. The first 6 trials are shown on the top, and the primary outcomes are shown on the bottom in the red outline. And they show a reduction in major adverse cardiac events of either no reduction for the first one, 13% down to about 26% for the one that lowers it most in these trials. So what we see is either a neutral effect on cardiovascular outcomes for the GLP-1s or up to a 26% reduction in cardiovascular events. So neutral or beneficial and no adverse events noted with GLP-1s. Next slide. The first slide was the primary outcomes for the GLP-1s. This actually lists secondary outcomes in the GLP-1 receptor agonist trials that we showed earlier. And this shows, again, cardiovascular deaths. There's a difference here. Some don't lower cardiovascular deaths. Others do a significant reduction, 22% reduction in cardiovascular deaths. So no increase and either neutral or a reduction in cardiovascular deaths for that. Importantly also is that all-cause mortality at the bottom of the first box shows a reduction that could go down as well by about 14% for that. And the bottom of the slide also shows worsening nephropathy. And notice that none of these agents worsen nephropathy. In fact, there's a reduction in diabetic nephropathy in all 3 trials that you can see at the bottom under the box red. So neutral or reduction in events, cardiovascular events, and benefit for nephropathy. Next slide. If we look at the next group that came out, the SGLT2, the sodium glucose transport inhibitors, what we see is in those first 3 trials there, we will show the next slide that shows the outcomes for these 3 trials. Next slide. And what we see in this slide is that the primary outcomes, that is the 3-point MACE for these trials, shows reductions in 2 of the trials of about 14% and no reduction in, or 7% in the other trial, which was not significant for that. So we do see benefits in 3-point MACE. If we look at the next box, second one down in red, we see these are cardiovascular events, and we see a difference that is either a 2% reduction all the way up to a 38% reduction in cardiovascular deaths or mortality. So no increase and either a neutral or a significant reduction in cardiovascular deaths for that. If we look at all-cause mortality, that goes down as well, anywhere from 7% down to about 32% reduction in all-cause mortality. So again, benefits for cardiovascular mortality and all-cause mortality. And the bottom box also highlights worsening nephropathy. And it's impressive that none of these drugs worsens nephropathy. In fact, they all show a benefit. And that benefit is anywhere between 40 and 50%, almost 50% for worsening nephropathy. This is important because SGLT2s work, or one of the mechanisms is in the proximal tubule of the kidney. And people were concerned if you had any kind of renal disease. They were initially not used or recommended, but it does look that the good news is, even though there may be a slight temporary increase or reduction in GFR, that overall the kidney will be protected if they're on an SGLT2 in these 3 trials. Next slide. So what do we do in individuals with existing cardiovascular disease? Yes, we turn to ACE or angiotensin receptor blockers, ACE inhibitors, as a therapy. If the GFR is below 30 in individuals, you have to be careful about metformin in the individual. And the SGLT2s are not recommended when the GFR is below 30 in this situation. Individuals with existing cardiovascular disease should consider as a priority that they be considered for an SGLT2 inhibitor or a GLP-1 receptor agonist, since both of these have shown the potential for improving cardiovascular outcomes. Next slide. So again, in the recommendations, it's repeated. Sodium glucose cotransporter 2 is recommended, and the GLP-1 receptors are clearly in the indications and the guidelines for these individuals. Notice the level of recommendation is A, meaning we have lots of data, and they're highly recommended in that situation. Next slide. Now, GLP-1s, in fact, are they all the same? Is it a class effect? Well, if we look at the second column from the right on this, which is primary composite CV outcome, just above the class effect sign, what we see is that the class effect here is difficult because we can see they're all GLP-1 receptor agonists, but the reduction in events is either a slight increase, 2%, or a significant reduction of 22%. So all GLP-1s in the trials do not seem to have the same primary effective or protective effect on cardiovascular outcomes, with different risk factors, some significant. So there does not appear to be a clear-cut class effect in the cardiovascular protection. They all lower glucose, no question. That is a class effect. But the cardiovascular effect does not seem to be spread across the entire class. Next slide. If we look at the GLP-1s for class effect, the column on the right, we can see again, yes, some have had benefits, significant reductions, 22%. Some have had no reduction in cardiovascular events, Some have had a reduction in MI that was significant, and some a reduction in stroke, and some a reduction in death. So they are somewhat different, and the class effect that is there for glucose lowering is at least spread across the board when we get to cardiovascular outcomes reduction and mortality reduction. Next slide. What we then look at is the SGLT2s, and the SGLT2 inhibitors, class effect or not. Well, yes, we saw that these drugs invariably, all of the trials show a reduction in heart failure. So there is a class effect in heart failure. They all reduce the rehospitalization for heart failure and the severity of heart failure symptoms in those individuals. Now, the question is, however, do they all reduce cardiovascular mortality? Well, cardiovascular mortality is either not reduced in some trials, or is reduced 38%, and all-cause mortality 32%. So although there is a class effect in lowering A1C and glucose, a class effect in heart failure in these individuals, and a class effect in renal protection, and those are all seen in every agent in the class, the effect in cardiovascular death and overall mortality is not uniform throughout this class. Next slide. So what are some of the reasons that SGLT2 inhibitors may be working? Well, we all know that they're diuretics. You're losing sodium and glucose in the proximal tubule. They are natriuretic. They affect blood pressure. They lower it through hemodynamics. They reduce adipokines, or inflammatory agents. They reduce fibrosis, improve vascular function, change ions. They change the myocardial metabolism. And some agents may also have less oxidative stress, reduce sympathetic nervous system activity, reduce albumin in the urine, reduce blood pressure, arterial stiffness, and you lose weight at the same time in these individuals. So they have a variety of factors that may be working, not just through possibly the SGLT2 receptor. These may be, as we consider it for statins, more pleiotropic with other agents and other changes as well that we encounter. And we'll have to do large trials to figure out exactly what these mechanisms and the most important ones are. Next slide. But despite that, we know that these agents can lower cardiovascular events and death rate in this population. In the EMPA-REG trial, the number needed to treat was 39 to prevent in individuals 1 death across the trials. And this is similar to types or number needed to treat when we look at statin trials and ACE and ARB trials as well. So similar to that, it has to be ranked in the level of statins and ACE or ARBs as far as protection in diabetic individuals. Next slide. So, is everything great about SGLT2 inhibitors? Well, we talked about efficacy and protection, but now we have to flip the other side and look at side effects. These are adverse effects seen in the 4 trials for the SGLT2 inhibitors. So there are side effects in these individuals. Top ones are seen on the top: male and female genital infections. These are often mycotic or yeast infections in the genital urinary area, and these have to be watched closely. Individuals and patients have to practice good hygiene for that. And those are seen as in all of the agents because there's higher glucose in the urine, so we could expect higher genital yeast infections in that particular case. Other side effects are seen as well. And if we look at some of the agents also have a little higher fracture rate and a higher amputation rate that is seen, but not present in all of the agents in the class. So we may want to be careful when we're picking it out. Individuals who have previous evidence of severe vascular disease in that situation, or problems with fractures, we may want to pick other agents within the class at that time. Next slide. So it is a balance with SGLT2s. On the left are the benefits: reduced A1C, reduced weight loss, reduced blood pressure. Who couldn't want those in your diabetic patients? Reduced major adverse cardiac events, reduced heart failure hospitalizations, and renal protection, all good things on the left. On the right, we have to balance it against an increase in GU, or genital urinary infections, a chance of diabetic ketoacidosis. It does not prevent or protect against diabetic ketoacidosis. And in some agents, an increase in amputations and fractures. Volume depletion in our elderly can be a problem in the heat, and a possibility of increasing the creatinine in these individuals. Again, that's a temporary increase. In general, there's still a protection against progression to renovascular disease. Next slide. Also, we do know with the SGLT2s, there may be additional protection, not just in diabetics. We do know that they are being used for heart failure, and there is evidence that there is remodeling of the metabolism in the heart, especially in the failing heart, to increase contractility, to increase ATP levels, to increase ejection fraction in those individuals. And it has been used in both diastolic and systolic heart failure individuals with or without diabetes. And we'll need further trials in this to figure out exactly who are the best candidates for this. Next slide. And lastly, as we said, kidney protection, kidney outcomes, shown the bottom for the large trials in the SGLT2s. Again, in the boxed red area, it shows that progression of albuminuria is reduced in individuals. So the key kidney outcomes in the class, all of these trials, shows a reduction in progression to renal disease, reduction in end-stage renal disease, and a reduction in individuals who have to go on to dialysis or transplantation. So real renal protection seen throughout this class, and should be a consideration for the individual who is diabetic, who has pre-existing or early renal disease. Next slide. So is it a class effect? Yes. Renal protection with SGLT2s is seen with every one of the trials that have been looked at where we're evaluating renal outcome. So this is clearly a class effect of the SGLT2s. Next slide. So what do we do for a patient who comes in? Well, we do want for our diabetics to assess albumin in the urine. It's not good enough to just get GFR. We want to look at how much albumin they're excreting at that time, because that's an important finding or alert that they're in fact developing early renal disease, in addition to monitoring their creatinine clearance. Next slide. And for the individual who has kidney disease and diabetes, we want to optimize their glucose control. Again, microvascular complications, including nephropathy, were reduced with intensive glucose control. We want to consider sodium glucose cotransporters because they are very protective in the individuals, and we want to continue that down until their GFR drops below 30. At that point, we are unclear as to whether there is protection or not in those individuals, but clearly those individuals who have a GFR above 30 would be considered candidates for it. Now, for some of the agents, the FDA has recommended 45. I think if you carefully monitor and closely monitor glucose, you may want to stay above 45 GFR. But the recommendation is there just so that you don't inadvertently get below 30 GFR when you're not monitoring the patient. The GLP receptor agonists are also recommended in individuals with renal disease. You saw there was some protection in that group or class as well that was seen class-wide. Next slide. Optimized blood pressure. We can say it again and again that controlling blood pressure is very important in the diabetic, and administering drugs that in fact control or inhibit the renin-angiotensin system is very important for those individuals. In individuals with active diabetes, chronic kidney disease control or reduction of protein intake may be important. Next slide. And ACE and ARBs are again important for this group of individuals. It's strongly recommended. And when they're on the ACE or ARB, you do need to monitor their creatinine and potassium levels to make sure they don't go too high. Next slide. And obviously, patients with chronic renal disease, you want to make sure they're not volume overloaded, their blood pressure's okay, and they don't get anemic, because anemia in chronic disease can complicate their cardiac adjustment to their metabolic problem. Next slide. And obviously, we are not nephrologists, so when they do get significant albuminuria and they do get significantly reduced GFR, referral to a nephrologist is important, because this is early on and these individuals eventually may require or progress to dialysis, and we want them to be working closely with the nephrologist at an early stage and to refer them early. Shown in the dark red and red is mild levels or moderate levels of albuminuria and GFR reduction in the 30 or 40 area should require us to consider treatment and referral to a nephrologist. Next slide. Lastly, we talked about efficacy, how these drugs can improve glucose, can lower cardiovascular events. Safety, they do have significant side effects that are usually well tolerated in patients. The third elephant in the room is the cost. This shows the cost of these drugs, and on the top, metformin, sulfonylureas are cheap. They are dollars a month that we can see, and patients can afford them, as well as TZDs. As we get to DPP-4s, the cost goes up significantly. Major increase in going to the DPP-4 inhibitors is seen, and it's also seen elevated in the SGLT2s as well. So these are significant monthly costs that a patient may have to bear. If there is no copay in the patient's insurance coverage, then this is fine, we're covered. But if their copay is hundreds of dollars a month, this can be a significant problem for access for those individuals. And that is seen with DPP-4s, SGLT2s, and goes up again as we get to the GLP-1s, another level of increase. So be aware of this. You may have the best medicines available for your patients, but if they cannot afford it and their insurance does not cover it, they may not be able to access these protective medicines. Next slide. This shows that not only are the oral anti-glycemics can be costly, but insulin cost has gone up as well. So remember that as many as half of your patients may also be on insulin. And these agents, although they're very effective and convenient to administer, can be significantly costly to the patient as well, costing hundreds of dollars a month at this point. So we have to be aware of that in our personalized communication with our patients. Next slide. And this is just in summary showing that the anti-glycemic drugs, all of them reduce microvascular complications. The newer ones that are SGLT2 or GLP-1s have been shown to reduce cardiovascular death and all-cause mortality. And it's important to pick agents that do both for our individuals with diabetes. Next slide. And this is just a graphic form of what we said is our final summary, and that is diet, exercise, weight control, lifestyle, education are important, and not smoking for all patients. Emphasize lifestyle. Beyond that, we go to metformin in individuals for control if they have existing atherosclerotic cardiovascular disease or high risk to get there in the next 10 years. Then we want to go to the left and consider a GLP-1, RA, or an SGLT2 in those individuals, or potentially both, although that could be very costly in that individual. If they don't have it, cardiovascular disease, will go to the right. You can use any of the agents in that situation, and SGLT2 and GLP-1s are still allowed and recommended depending on patient interaction and cost access at that time. Next slide. And so we showed we can do a very good job, but the reality is few of our patients achieve our target risk factor reduction. Shown here at the bottom, all targets achieved in 21%. I showed another study at 14%. We're doing a very poor job, so we need to improve upon that. Next slide. And this is just a personalized approach that can be used in individuals where we look at all of the features of efficacy, hypoglycemia, cost, kidney, cardiovascular effects on this chart. And then we balance it with, you can use this chart for GLP-1s, SGLT2s, DPP-4s, TZDs, sulfonylureas, and insulin, and it contains all of that. This is a chart to sit down with a patient when you're picking their actual plan, how to go forward, to show that, or to pick out or compare different agents and their effects for your patient in the intensive clinic. Next slide. And this is just a flow chart to show the same thing. You can start out and say, what do we need to use? And clearly in individuals, we can use additive glycemic control in this particular situation for it. And if cost is a major issue, unfortunately, you're swung to the right where you're depending on sulfonylureas and TZDs, and you will not get the cardiovascular protection as you can get if you swing more to the left. And as you swing to the left with cardiovascular disease, we certainly want to recommend agents that have both a cardiovascular protective effect, a renal protective effect, as well as a glycemic effect. Because 2/3 of your patients or more, 70%, are going to die of cardiovascular disease rather than another diabetic complication. Next slide. And so this is the final slide just showing that number one, we recommend lifestyle in our clinic: diet, exercise, weight optimization, smoking cessation and counseling, education. And in our new clinic, we recommend COVID precautions. Diabetics are higher risk of getting COVID-19 and of developing a life-threatening or fatal complication from COVID-19. So that has to be included in the new diabetics lifestyle modifications, which is the foundation of any therapy program that you have. When number two, if we add medicines, we want comprehensive risk reduction. That includes for blood pressure, ACE or ARB, also useful for renal protection, lipid therapy, statins, and glucose control with drugs that in fact have been proven to improve outcomes in cardiovascular patients, including metformin, GLP-1, and SGLT2 drugs. 3, glycemic and blood pressure therapy have to be individualized. No patient coming in is the same as the next one, and each one is different, and your therapy and success are depending on your ability to assess that individual's response and their inclination to follow you in that therapy. Combination therapy is going to be required in many diabetics for that with oral and or injectable agents. And ultimately, as many as 50% of your patients will require insulin. So it's not a failure to go to insulin, and tell your patients when you get to that, that that's an expected course in the time course of diabetes. And all treatment decisions should be made in conjunction with the patient. Remember, focus on their differences, their needs, their values, because that, in fact, is the secret to your success in treating these individuals. Next slide. And that is conclusion of our presentation today. I would refer you to the complete recommendations that are listed here in the Diabetes Care of the American Diabetes Association, available online for you for your version, and pocket cards are available as well. We skipped over some things because of time, but the complete recommendations and guidelines are available in this publication. Next slide. And lastly, as we now migrate from our intensive clinic to our now remote clinic, you want to, in fact, discuss all these issues with your patients, lifestyle, medications, use technology as it is, and remember that there are psychosocial aspects of diabetes that are important to get better access to therapy and accessibility and acceptance by your patients. Remember that on the right, COVID-19 has stepped in, and everything that was done face-to-face in person is now being done face-to-face via video at this time. And we can do video charts, we can do video exercise, video cooking, video education, and video counseling as well with our patients. And we have to use that at this time in the setting of COVID-19. Thank you for your attendance today. I appreciate your sticking through. We got a little bit of a late start, but I think I'd like to roll on to the next session at this point in time, which is going to look at insights from our organizations within the Bay Area as they address COVID-19.
Thank you, Bill. I think Nirali is there to introduce the next portion.
Yeah, thank you so much, Bill. And we said we'll take questions at the end. There was just one quick clarification from Scott Flynn. Did you discuss the use of GLP-1 inhibitors before instituting insulin? Bill?
Yes. GLP-1 is before insulin. Yes, we would recommend in those cases that because they are cardioprotective in many situations, and insulin is not. We've looked at insulin and a number of animal trials and other ones. Insulin slightly raises your risk of cardiovascular events. 4%, not a lot. It's a small increase. We think it's related to the insulin receptors very close to the beta receptor in the heart, in the myocyte. And you may cross-stimulate when you give higher levels of insulin, the beta receptor. That may lead to the slightly higher risk of arrhythmias and other problems. So we would prefer going to GLP-1 and SGLT2s before moving on, before going to insulin. Insulin is your backup. The GLP-1s and the SGLT2s don't lower A1C by more than 2. And so you may need clearly insulin when you come in with a diabetic with a high A1C. So insulin's there for backup, but we try to use the other agents earlier rather than later to prevent cardiovascular and renal problems.
Thank you so much. So I see there's some other coronavirus questions. We'll wait till the end. We thought we'd spend just a few minutes per individual up next to talk a little bit about coronavirus sort of on the front lines and how the health system is dealing with the situation. I'd like to invite Eleanor Levin, who's here also from Stanford, to give a perspective on this. She's a professor of medicine and a cardiologist here, and she has done work with Kaiser as well. So Dr. Levin, are you with us?
Yeah,
Would you like to show yourself?
Yeah, sure. The video is disabled. If you want to start it, that's okay. But
yeah, so maybe just a few minutes, since we're running low on time, to hear your update before we move on to Edward Yu from PAMP.
Yeah, so very easily, Stanford is well ramped up. They went immediately to video visits. They were going to start with just the physicians over age 65, but because the younger cardiologists had childcare problems, they immediately gave out laptops to all of them as well, and everyone is on remote video visits. The patients have adapted very well. I can't see my own face, so I can't tell with my face. All I see is Stanford. They put my face in there. I can't tell. I'm looking at it, but I can't tell if my face is there. Oh, looks good now. Very good. Okay, so onward. Currently, as far as the hospital, they're very well prepared. They reopened 2 ICU units that they had closed when they went to the new hospital. They're setting up extra teams with 4 residents and 1 attending. They've asked for volunteers. But currently at this moment, as of 2 days ago, they only had 13 patients with COVID in this large medical center, and only 3 over at the Children's Hospital. Similarly, so they're all geared up, ready to go. The ER volume is actually half of what it usually is. And so they're doing a fabulous job to be prepared. And it looks as if, at least in the north part of the county, the social distancing is making a big impact. My friends at Kaiser have let me know that they also have increased their ICU beds. I don't have slides. So they originally had 30 ICU beds. They're up to 50 ICU beds, and they have room to make 150 ICU beds. They also have increased their teams, and they've pulled young attendings off ambulatory and pulled them to potential hospital duty. They've also pulled the anesthesiologists who aren't doing routine surgery procedures to the ICU and the cardiologists, while they pull the surgeons and the dermatologists to phone duty and triage. And that's all in prep. And they do have, I don't know the exact number of patients they have at this moment, but they do have more than Stanford Hospital does at this time. Kaiser San Jose is farther south in the county, and they're more highly impacted with about half the hospital are suspected COVID, not documented COVID. And it is quite a bit smaller hospital than Kaiser Santa Clara, which again is about 2/3 of the size of just the Stanford Hospital. Both Stanford and Kaiser have set up places for doctors to stay who are exposed, who don't want to expose their families, in hotels at discounted rates that were empty because no one's traveling, and also emergency childcare because all the daycare centers have closed and their kids need to be supervised if they come to work. So that's sort of my understanding of the Kaiser Santa Clara and the Stanford update, but that's North County.
Thanks, Dr. Levin. And I'll just add, as a neurologist on the front line for Stanford, 2 more points, which is that currently our PPE needs are appearing to be adequate, although there's lots of guidelines about how to monitor. And I completely agree with Bill Bommer's recommendations about limiting the number of individuals who really require entry in a room, the use of telehealth for both inpatient and outpatient as screening, and really leveraging technology to protect our healthcare workers. As although, the sheltering in place does seem to be having an impact, we do expect higher numbers over the next couple weeks on the data projections. So I think that having everything in preparation and clear lines of communication are super helpful. And then I just bring up in a unique point that we really do need to advocate for ourselves and have more moral courage as healthcare providers in this time frame, and have good communication with our healthcare administrators. As a person who responds to stroke codes, one thing we discovered was neurological patients, for example, or any code, perhaps a cardiac code, patient is often unresponsive, aphasic, altered, or unable to provide screening questions. And so we really need to have a heightened level of masking that patient and protecting ourselves to the best of our ability with what we know can protect us right now. And so sometimes people aren't always thinking about the STEMI patient or the stroke patient, and we need to advocate and be a voice in that end. Let's move now to Ed Yu from Palo Alto Medical Foundation, the Chief Quality Officer there. Ed, are you with us?
Yeah.
And you can show yourself
I
if you
am.
like.
Oh, thank you. I have no slides. That's me. So thank you for sharing the Palo Medical Foundation perspective. The first case in Santa Clara County actually was diagnosed in our facilities and then had to be hospitalized at our partner hospital, El Camino Hospital. And when that patient came through, this was before all the systems were in place. And as a result, over 4 dozen healthcare workers between PAMF and El Camino Hospital had to be self-furloughed for 14 days. And that rapidly was put a fire underneath us to put our systems in place. So one of the first things we did was to put in screening for our patients, to early identification of these patients to protect them and prevent exposure to our staff and our patients. As a result of that, we, like a lot of ambulatory systems that have done this, we have rapidly had to set up respiratory clinics, which were outside of our building in our parking lots to manage these patients. And we had to rapidly, so over the weekend, Palo Medical Foundation has about 48 sites. And then we had to, overnight, had to have half of them stood up because at that time, before the shelter was in place, we had to have a place to see these patients and try to prevent patients coming into our buildings where our high-risk patients are still coming for care. I mean, things have since stabilized. We have a very good workflow. Actually, right now, all patients that have acute respiratory symptoms won't be able to come into our clinics and directly channeled to our respiratory clinics there for management, and that process is going well. Once the shelter in place was put in, we were asked to offload all deferred care for chronic and preventive care, and that has really shrunk our business by 80 to 90%. And like Stanford and Kaiser, we also flipped to doing video visits and other telehealth to monitor our patients, all of that. From our perspective, PPE also, we at this point are doing okay. We are very grateful for our community and our business partners who have stepped up and willing to donate PPEs to a point that we did not expect. So likewise, for our county and our system, we have adequate PPE to weather through the expected storm and the surge of this. Likewise, we're working with our hospital partners to ensure there is capacity to deal with patients which will need to be managed to the inpatient side. And just this morning, this is Sutter overall. We are positioned well. Our ICU capacity stands at 50%. So we are well positioned to absorb additional patients that come into that. So I think from a inpatient ICU bed ventilator perspective, from a PPE part, I think we are in good position to support our patients during this crisis time. One of the things we're starting to think about is that we're building a huge backlog on deferred chronic and preventive care. And we're also starting to think about how might we bring those patients back and engage them in a way that keeps them safe. And then I think our community is waiting for us to see, all right, for our frail diabetic patients who have chronic conditions, how do we make sure they don't fall through the cracks, particularly if COVID, with the shelter in place gets extended. So we're starting to think about that and how to meet our community need in that space. And then how do we ramp up and then really transforming the way how we interact and care for our community. Because I do think the post-COVID world that we're going into, at least from our system, we see our operating model and the way how we engage and treat patients. It's going to be very, very different than in the pre-COVID world. So again, it takes a crisis like these to drive major transformation in our system. And I think the final point I would say is that we are also very active in the advocacy front to ask our payers and our government to relax regulations to allow us the flexibility to meet our patients where they are. And also we have to want to bring up that there's a huge financial impact on all of us here where our business model is based on in-person visits, of which we should not be doing because of the shelter in place. Then how do we allow funding and from our payers to support the work that we do for our patients that we deal with virtually? And I'm grateful to say that our advocacy efforts together with other organizations, leveraging our industry partners and our individual specialty societies, has been successful, that at least all the payers are right now allowing us to meet our patients where they are and allowing a funding stream, because one of the concerns that we do have is, as this extends longer, what is the impact on smaller offices who may or may not be able to transition, survive through this. So I do think that all these factors come into play and really drive the fact that as we go through this, the healthcare provider industry that we have is potentially going to look very different than where before COVID-19 happens. But again, the ending point, I want to say that our health system here is well positioned to meet the anticipated surge in cases. We do also share that our county and our government and our public health department have been proactive, and we're one of the first counties that went into shelter in place. And also we do see the impact of that, because our anticipated volumes in our respiratory clinic has been less than we have. We take it as a good sign. And again, we are well positioned to meet our community going into this. So thank you.
Thank you, Dr. Yu. I want to bring up that point. I want to thank everyone for their participation in social isolation and helping our systems overall. I think that keeping patients who don't need to be in the hospital out of the hospital is such a critical component. And I think all of our institutions have done drive-by COVID testing and other ways to kind of keep those inpatient rooms open. I also think that the government has come through and released, have placed HIPAA waivers and other billing support so that we can continue and really just maintain our established patient visits. As far, I don't know, Ed, if this is what you're doing, but we are definitely trying to just retain our normal clinic approach for new and follow-up patients, given the laxed rules to just maintain our volumes. And so I think we all need to kind of get that in our minds. And really, I think that there could be some silver lining here, that patients who may have had to travel from farther distances, for example, will get access to care, particularly counseling in our population who may really need it, even seeing their home and their family members as part of the visit, and helping to think about their care long term. So it's just past 6:30, and we wanted to open it up to individuals who may want to share on their experiences with COVID. And then there was one question that I'll just put out there if anyone has an answer to. Sorry, I just have to scroll back through that that somebody asked, and I think Brian will be unmuting everyone shortly. But where did that question go about coronavirus? It was about how coronavirus really does lead to the mechanism of action of how coronavirus leads to cardiac problems. So here we go. Paul Miskowski, apologies if I mispronounced that, asks, do we know if corona causes cardiac morbidity via direct effects, viral infiltration of the myocardium or endothelium, or by indirect effects, inflammatory, neurohumoral, or some combination of both? So I hope, are we all unmuted? Or sorry, you will all have the capacity to unmute yourself. Please don't unmute yourself unless you're speaking. And if anyone has an answer to that question, Bill or others, feel free to chime in. I think that there's a lot of research going on to try to understand this, and we can see if others want to comment on their institution's response.
So the answer is yes, there is. The COVID-19 can get into cardiac cells, take over the RNA, and thus interfere with both the ion channels in the cells, as well as the myocytes for contraction. So the ACE2 protein is present in a lot of cells and organs in our body, not just the lungs. And so it does have access to all of those cells and organs. And obviously in there, it takes over the RNA. And once you, in fact, fill the cell with virons rather than the normal structure of the cell, you can expect cell dysfunction, initially in arrhythmias, and then eventually in contractility for the myocytes. So yes, it's directly gets in, and that is certainly a contribution to some of the complications.
Thank you. Okay, is anyone else from another Bay Area institution, maybe first or even outside of the Bay Area, wishing to comment on other innovations that may be happening in the era of COVID to help our patients? And if you aren't being unmuted, maybe you can just private message Brian, or sorry, Right Care Initiative, the host, and he can unmute you, since it looks like everyone is still muted.
In our planning call, this is Hattie Hanley. Can you hear me?
Yes.
Yes, we can.
Wonderful. So we had a series of practice calls, planning calls, building up to this Zoom session where we heard fairly dramatic stories from each of our institutions about real concerns about how the personal protective equipment was or was not being effective. And in particular today, we heard a story from one of our team members that 3 out of 5 prepared staff members actually became COVID positive. Would you care to speak about that? I don't want to call out the institution unless you want to talk about it.
Well, I think I'm being called out at this time, so I'll respond. We obviously get patients with COVID-19 transferred from other hospitals. So we have a tertiary system, and the initial COVID-19 patient we had was transferred from another hospital in the Bay Area to us for treatment. And that was the first community-acquired COVID in the U.S. We have received other patients from other hospitals that are not in Sacramento County, that are in areas of the state with a low incidence or prevalence right now of COVID-19, who have turned out to be COVID-19 positive. And their presentations have been atypical, stroke in one case. And so the difficulty comes up when those patients come in and they're not clearly COVID-19, they're not from a COVID-19 area, contact, or source. What type of personal protective gear do you use? An individual was required intubation 5 days, after, or 4 days after they arrived. As I said, 3 out of 5 individuals in the room are now COVID positive of the staff members, despite the best efforts at personal protective equipment, easy intubation, et cetera. So I think it's a concern that we all have. Any procedure that a healthcare professional or practitioner does that potentially involves aerosolization going beyond droplets is high risk. And in this individual, nothing in retrospect seemed to be aerosolization could be not documented in the case, and it was there. So I think when you're asked to do a procedure that has a known aerosolization, I think you have to prepare with everything before you walk in the room. Because even though you would say, hey, this was easy, there was no cough, nothing else, you just don't know what is available. And I think healthcare practitioners have to be especially careful in this setting where atypical presentations may be disguising as COVID-19, and it in fact leads to the virus getting a start in the staff of the hospital.
And thanks, Bill, for sharing that scary but truth. I'll also share my own experience and just really, you know, again, a PSA for the 20-second hand washing, but also being aware of the high asymptomatic transmission rate that could be among other providers that aren't being tested right now, as not everyone is being tested. And so really being cautious with your workspace, your computers, wiping things down, and, you know, not unnecessarily exposing yourself when you're in the hospital to those other means, or being very mindful that even the workrooms could have risk. So just, I think we're all being cautious not to create over hysteria, but just really being responsible so that we can continue to participate in the care of our patients and help, you know, stem the tide, whether it's through managing our outpatients and preventing them from getting sick and going into the hospital, or in the hospital and helping these patients stay alive. All right, any other comments from the community? You can all unmute yourselves at will now. If you want to share either questions for Dr. Bommer about his presentation, or even if we just want to share as a community our current response in the COVID era, either questions you have or solutions you want to share from your organization. And maybe just say who you are, since we're from all over the state right now.
I wonder, we have some amazing participants still with us, 43 people from around not only California, but we were even joined for a little while by the US Surgeon General's office. We have medical directors from many large institutions around the state on the line, but I don't want to call on people unless they want to speak. So I don't know how to see the indication of who would like to participate, but for instance, thank you very much to California Department of Public Health for participating, the Office of Statewide Health Planning and Development, many of our major insurers and health systems have been on the line with us. Many still are on the line with us. A lot of the biotech companies are with us. And with that, I'll just be quiet and see if anybody wants to jump in. And before I say that, Nirali, you had asked if we would go around and have everybody talk about something that they're grateful for. And I'd like to say I am so grateful for all of our supporters, especially Blue Shield of California, Medical Director Dr. Scott Flynn, who was my first co-chair in our first pilot community in San Diego, our first regional university best practices. And he challenged us to start the new group in the Bay Area. And I have to say, I feel that it's been an amazing experience bringing together Stanford, Kaiser, UCSF, Palo Alto Medical Foundation. It's really been a wonderful experience for the Right Care Initiative to grow into the Silicon Valley area. And also thank you, Dr. Flynn, for challenging us before the COVID-19 virus to learn how to carry out these meetings virtually like this.
Thanks, Hattie. And actually, I didn't mean for all 77, or I guess now 40 people to have to say it. But one thing I think we can all appreciate is in these times, there needs to be space for ourselves and for gratitude for our community and for everyone who has helping us both at work and at home. So as we're closing this session, if you want to send a chat to everyone, just noting what are you grateful for, that can be a nice thing to just see that positive energy, which I know all of us, especially those of us on the front line, could use right now. So if you'd like to participate, this is just for us. You can set your chat to everyone and maybe just one line on what you're grateful for in the current environment. Go for it.
And we are ever, ever so grateful for all those frontline practitioners, many of whom are leading this group: Nirali, Vora, Evelyn Stock, who got called off to do patient care at UCSF, Bill Bommer, who does coronary ICU at UC Davis, and Dr. Bommer, thank you for that amazing program that you presented today. I know that you are a walking dictionary, but you're also, unlike a lot of professors, you're out there on the front lines caring for these critical care patients, and have in fact probably been a little bit too close to that patient one that came in from the county in which Travis Air Force quarantined people, the first community acquired case that was transferred to UC Davis. So very brave group of people leading this care, and we just couldn't be more appreciative.
Well, seeing the messages coming in is so heartwarming. I hope before we all leave today, people can just scroll through and see it. It brings a smile to me to see what we can find positivity in right now. So thank you guys. And I think probably no one has more questions. So Brian, there were some questions about, or if someone wants to comment about CME for the session, or if you'll be sending out an email on those technical details.
Yep, just wanted to let everyone know that a follow-up email regarding CME will be sent in the next day or two. And so please look out for that. If you do not receive that email by the end of this week, please feel free to reach out to the Right Care Initiative to get that sorted.
All right, any last words, Hattie? Otherwise we can close the session.
I would just say let's be extra ultra careful, because what our healthcare leaders on this planning group have described in terms of the risk to our frontline healthcare workers is just immense. And so please don't hurry. Please think long and hard before you take any unnecessary risks. So Nirali, I'm glad that whatever exposure you had, you appear to have tested negative, and that is really true for almost all the healthcare workers on this call. Bless you all. And thank you to all of our supporters who make it possible for us to continue meeting virtually.
And thank you everyone
Patty,
for attending at the end of the day. I know it's a long day. And for those of you who have also lost friends or family members during this pandemic, our hearts and thoughts go out to you and your family. Thank you for joining us today.
Thank you.
All right, goodbye everyone. Thanks. We'll see you next month.
Thanks for leading this, Nirali.
Oh, no problem. See you guys.
Take care. Take care, everyone.
Bye, Hattie. Bye, Nirali. Thanks, everybody.
Thanks, Cece. Thanks, Robin. Thanks, Scott. Thanks to all of you who stuck with us here. So we had, at the height of this meeting, I was counting something like 82 people, might have been higher than that. And I forgot to thank Dr. Ed Yu. I have to say, Ed, I see you're still signed in there, and I just love the enthusiasm that you've brought to your leadership role with building out the Bay Area right care university best practices, and this spirit of we're all in this together, and let's take off our hats of whatever our institution is and let's solve this problem for the patient.